Okay,
All right,
chronic cough today.
Chronic
We do-
let's do our learning objectives. So differentiate between acute and chronic cough, because obviously your workup is different. Understand the workup for chronic cough, which is fairly straightforward, but I don't think it gets done often enough. And know the stepwise treatment for chronic cough. So actually treatment is part of your workup. So kind of that stepwise process is important.
Okay, we got a case. So 65-year-old presents with 30-factor history of smoking and a cough that progressed over the last year despite not smoking for the last 5 years. He says the cough is non-productive and unresponsive to bronchodilators and nasal corticosteroids. The exam, x-rays, and PFTs are unremarkable, and the question is, what should you do next? So, should we start with some background facts?
Yeah.
So chronic cough so that was one of our objectives, it's more than 8 weeks of a cough.
8 successive weeks.
8 successive weeks, and these folks, at least in my experience, are at their wits' end. And because it's this miserable symptom and it's often hard to parse out. And it can be, they often seek help from multiple different physicians because your differential is huge, right? It's everything from infectious to reflux to ENT related.
No, that's why I think it's important to figure out what other people have done and what they've done over the counter, although over the counter stuff is pretty useless. I'm not
Yep.
sure I differentiate a lot on that. I think it's important to note that if they're big sputum producers, this doesn't apply to them. There are chronic coughers with big sputum production. That is a total different
Yep.
topic. This is for the dry, kind of nagging, irritating cough that you get when you're talking a lot or, it wakes you up at night, those kinds of things.
And I can remember, the patients that I've had with this, I can remember because
I
they
can
come in
too.
so frequently.
You get to know them really well.
Yeah, because they're miserable and you're like, oh, they're on the schedule and I'm not sure what I'm going to do for
Right,
them
what's
today.
next?
Yeah. I like the article was a New England Journal. I think it was a
October 20th.
yeah, and we'll put it up. I think it was a clinical practice
Yep.
article, and they broke it down into 4 steps, which I like, 4 easy steps. And the first one is identification and treatment of the obvious. Seems like a good way to go. So what do you guys think would be the obvious? What do you want to do to start with? It was already done in this person, right? A good history and physical.
Yeah, very good.
Very good history and physical. If you hear crackles, if they're a big smoker, they have hemoptysis or weight loss, then you're going to totally put them in a different bucket. Also, what about medications?
ACE.
Yes, very good. I don't know the number they cited was 21 in 5 will have a cough.
Seems
on
like
ACE.
more than that.
Yeah, I didn't think the number was quite right.
Yeah.
And so a basic good history, review of medications, an x-ray, and spirometry can really
Yeah.
exclude a lot of really sinister things. And then the
And I think spirometry is what I often see forgotten.
Yep.
Because again, I'm not talking about the COPD or with chronic bronchitis, because they're sputum producers. So these guys typically don't look sick. They typically aren't smokers. And so I think a lot of people miss that spirometry as one of the basic workups.
Yeah, exactly. And then, so you've gone through step 1. Step 2 is focused treatment of common causes. Seems totally reasonable because
Yeah.
there's not the diagnosis is clinical, right? And we're sort of just, I think the frustration is, as internists, we like to work to a point.
Mm-hmm.
And in this case, what we're doing is scratching things off to get to a diagnosis because it's almost a diagnosis of exclusion, right? So the 3 common causes of chronic cough.
GERD.
Good.
GERD, yeah.
Medication.
That's in step 1.
That's in your history.
That's step 1.
We've already gone past that
Sorry.
now.
Diseases,
Good
not
point. Yeah.
so diseases. Sorry, I didn't.
Not iratogenic.
Yeah.
Non-iratogenic causes of chronic.
So GERD, what else? Oh,
Post nasal drip.
good. Allergies and postnasal drip. What else? Asthma. Good. Yeah, and so
And they may have no shortness of breath.
yeah.
They may have none, especially these guys that have fallen in this bucket. You've probably already ruled out the people that had shortness of breath.
And so yeah, and then what they kind of suggest in the article is see them, try to put them in one of these 3 buckets, and treat the obvious. or treat what you think is most likely, because
Right,
obvious is a bad term, because a lot of times you're not quite sure.
right.
And it was interesting, we do the PPI trick quite a bit. I thought the article, I don't know what you thought, was kind of double
It was
talk.
cynical about that.
It was, but then they said, you know what, it seems to kind of work sometimes, and it's probably the best we have to offer.
Right.
And so,
They actually kind of went into what I thought was cool, I've never thought of it, is like that reflux isn't because it's coming up the esophagus and going back down the airway, but it's actually kind of a vagal sensitization, so the reflux goes up in the esophagus and then vagally triggers a cough. And I've never really even thought of it that way. I've always asked when you got that backwash, at night and those kinds of
Yeah.
things. And so that was kind of interesting. The other thing about testing for asthma is I don't start this way, but if you've worked through all these other things, but your spirometry is negative, you should go to a methacholine challenge.
yep.
So you haven't ruled it out until you've done that.
And they also suggested sometimes people that are taking inhalers, they're not using them correctly, and the medication can be an irritant that actually is the cause of the
Gives them
chronic.
more cough. I
gives them
bet you
more
that's
cough.
very common.
And so simply giving them a spacer can be curative. If you're going to do the PPI trial, it's BID for 30 days. And then right now, this time of year, I think probably our most common is postnasal drip because there's allergies everywhere, right? Certainly we have some sufferers probably in the audience. And antihistamines or nasal corticosteroid trial can be helpful.
And I think it's important for to not start ones. Usually I preach against this, so this kind of goes against what I usually say, but I think it takes a combination of treatments often. So like an inhaled nasal steroid and treating for asthma. Typically I say don't forget to stop what you already tried if you're going on to your next diagnosis, but in this it's typically multifactorial.
Yeah.
I think the link between reflux and asthma is weaker than what it used to be, but I still think they can all be tied together.
And then if they come back again, they're back on the schedule. And you
Which
think,
they will.
oh no, what do I do for this person? Send them to the specialist, right? Which is
You don't want to see them.
It's three, yeah, specialists doesn't want to see them either. Evaluate for the uncommon, and what I would say is, as with chronic cough, you have to pick the right specialist, which can, in this case, be a challenge, right?
Yeah.
And I think one of the things that comes to mind is, well, let's send them to pulmonary, and then you're talking about things like eosinophilic bronchitis, sarcoid, maybe a foreign body, and basically I think what we're asking is, do you think it's worth doing a bronchoscopy?
That's exactly, and I think you should say that on the consult. I've done everything, does he need a bronch? Don't just say I'm sending him because of cough or whatever.
And I think one thing we can do for our patients is tell them what to expect. So how often do you guys think they find an answer when they do a bronchoscopy at this point? So you've been through the trial of nasosteroids, maybe some loratadine, you've done the PPI for 30 days. Oh my gosh, that's like 6 visits. They did a spacer, asthma medications, methylcholine challenge. This person's frustrated, they met their deductible.
That's right.
10%.
All right, somebody read the hand.
Good job.
Yeah, so 10%.
But it's still very important to do because it can be the fatal stuff and those kinds of things that you'll miss. So if you've done the workup and it's all negative, it's worth it for that because those 10% of things is very important to find.
And honestly, when I think about myself getting a bronchoscopy, it's not something I would want to do. But the people that I've had are so desperate because this is such a miserable thing.
It affects them socially.
Yeah. They're just like,
Psychologically.
10% sounds great.
Yeah.
You know?
Wow.
Yeah.
I'm sure I'm in the lucky 10.
So if they're not, then we're left with management of refractory cases. So what can we do for them at this point?
We've ruled out everything that we can.
What I took away was the reassurance is a good thing.
Yeah.
You've ruled out the sinister causes. The natural history is this often gets better.
But it
And
can take years.
it can take a long time, and there's some things that we can try. There's no FDA-approved medication for chronic cough. There have been some things that have been tried. Interestingly enough, morphine, sustained release 5 BID was studied.
I probably will never use it.
I don't think I'll use it either. 1 in 3 responded, but half didn't. So, and not shockingly, or I guess a little bit shockingly, but not so much so, our patent medicine of the century, gabapentin, was tried. We try it for everything.
Boy, they're good, aren't
They,
they?
yeah, exactly.
But if you think about it, if there's actually this vagal nerve trigger
It's
that's
got some-
causing
it's got some
stuff,
science
I
behind
think it's got some, it actually makes a little bit of sense. And pregabalin, same thing.
Yep,
Yeah.
and 12-point improvement on a 100-point scale, trying gabapentin. So maybe worth a try. Amitriptyline was better than codeine and Mucinex.
And low dose, it's really low.
Yeah, low dose, only 10 milligrams. The other thing is speech path can help some of these people in terms of kind of working as swallowing instead of coughing.
Kind of control of that. I think you almost get triggered, like sensitive, and you're too sensitive to triggers to cough. And speech can help with that. quite a
Yeah,
bit.
and one of the last things I think that was so important is this poor person has been through, they probably got a prescription profile now that's this big, right? Because we've tried inhalers, we've tried PPIs, we've tried antihistamines, and so I think it's important to go back and get rid of
Weed
the
'em out.
stuff that's not helping them. There's no reason to give them those medications if they're not working. And then good reassurance.
Yeah.
So what do you guys want to do for this person? So 30 years old, former smoker, normal x-ray, PFTs.
PPI.
I would do a 30-day trial with PPI. I would make sure they have a spacer, and I would consider addition of nasal corticosteroids. And if they come back after a month and aren't better, then I would consider referral for bronchoscopy and start discontinuing medicines that aren't helpful and reassurance.
I do a methacholine challenge
Yeah.
for the bronchoscopy.
Yep,
Because you don't know that they're using those inhalers correctly. You just can't let that
yep.
rule out disease. All right, so our key points. Chronic cough is more than 8 weeks in duration, and excessive sputum with chronic cough would likely be related to bronchiectasis or sinus disease, so it doesn't fall into any of these recommendations that we're talking about here. Chronic cough has many triggers and can be a symptom of multiple respiratory diseases, so get ready for the long, tangled workup there. Initial evaluation includes history and physical, chest radiogram, and spirometry, and clinical trials, which they admit in the article is not the best done trials, but it's all we have. And these people, like Dr. Birch said, are willing to try almost anything. Does show benefit of low-dose morphine, gabapentin, or pregabalin. And amitriptyline should have been up there too. So, there you go.
So.
Okay.
Thank